Fall Prevention by Rachel Ronay,
Anne-Marie Jacobson,
Kaisha Lindsay.
Kelly Zavala.
The problem is we are seeing more and more falls in the acute care setting at the hospital as an inpatient. Most of these falls are preventative. Falls are a problem because they can lead to increased length of hospital stay, an increased cost for the hospital, and a decrease in patient satisfaction. Falls can lead to harm to the patient or even death to the patient. Currently, different facilities have different practices for fall reduction, and the practices vary from facility to facility. Some practices that are currently taking place are having the patients wear non-slip socks, activating bed alarms and chair alarms, having in-room video monitoring or one-to-one patient monitoring, implementing a falls risk assessment, and physical and occupational therapy. The PICO question that we are exploring is, among acute inpatients, how does an hourly rounding program impact fall rates over a 60-day period? According to the American Nurses Association, hospital falls are associated with longer patient stays, increased hospital costs, and loss of autonomy. If nothing changes, hospitals will continue to acquire preventable costs. Patients will sustain unnecessary injuries. Patients will lose trust in the nursing staff. Hospital ratings will decrease. And patients will be staying in the hospital longer.
Our proposal for our evidence-based research project is introducing purposeful hourly rounding to prevent and decrease the number of patient falls. For our evidence-based presentation, we conducted a comprehensive literature review. We have selected 5 articles. Some are quantitative, some are qualitative, and some are mixed methods. Below are listed the following.
The first research article is called The Implementation of Intentional Rounding Using Participatory Action Research. According to the article, nursing staff focus was primarily on the response given after a request was made by a patient, rather than prevention ahead of time. If nurses made more regular and frequent rounds of patients through intentional rounding, then would patients be more willing to wait for assistance rather than hit their call light? By completing intentional rounding at set intervals, healthcare professionals would be more apt to anticipate a patient's needs versus waiting for a call light. The design was a qualitative method approach. It emphasizes on participation by all relevant players, including collaboration between the research study and participants. It encouraged revision and assessment of the intervention. The research method was a participatory action research. It had emphasis on participation by all staff, including research and study participants. Both participation and action is key to this research, and the aim is to improve health by involving the people who would ultimately take actions to improve it. The measurement tool, a research advisory group consisting of the director of nursing, nursing service manager, the nurse in charge of the ward, and the research project manager, was established to oversee the project. The findings showed intentional rounding has been shown to create a more rewarding nursing environment via improved time management, patient care team, communication, and rapport. This places the patient at the center of attention, thus reducing the use of call bells and improving nursing staff and patient satisfaction. The reference is listed below.
Our second article was hourly rounding to improve nursing responsiveness, a systematic review. The question was synthesizing the evidence concerning the effect of hourly rounding programs on patient satisfaction with nursing care and discuss implications for nurse administrators. The design is clearly listed in the title of this manuscript. It's a systematic review, and it describes a systematic review of literature reviewed directly by research questions that strives to recognize, evaluate, and integrate relevant research evidence. The measurement tool was an experienced research analysis, reviewed the titles and abstracts of all articles found. The analysis also identified potential sources of bias or uncertainty. The findings of this article were the systematic review determined that the evidence supporting the use of hourly rounding in inpatient care was of low to moderate strength. These findings in this article suggest there is little consistency in how results of hourly rounding were measured, precluding a quantitative analysis. And then reference.
Our third article was hourly rounding and patient falls. What factors boost success? The question for this article was falls are a persistent problem in all healthcare settings, with rates in acute care hospitals ranging from 1.3 to 8.9 falls per 1,000 inpatient days, about 30% resulting in a serious injury. The method used for this was a convenience sampling. A convenience sampling is a process of selecting individuals to be in the sample who are accessible and or volunteer, also called accidental sampling. The measurement tool used in this article was the Mann-Whitney test, which was used to compare baseline fall rates with project period fall rates for Unit 1. This article did use 2 units. It used Unit 1 and Unit 2. The one sample, Wilcoxon Sign Rank Test, was used to compare Unit 1's pilot and baseline period fall rates, Unit 1's project and pilot fall rates, and Unit 2's pilot and project fall rates. The one sample Wilcoxon Sign Rank Test was used to allow comparison between the two of the fall rate measures for both units, periods, and the fall rates from the other study periods. The findings in this article states by incorporating an hourly rounding program into a pre-existing fall prevention program, it has been shown to not only strengthen the existing program, but to also decrease the current fall rates. The active involvement of both leadership and frontline staff in the program design and as unit champions during the project run-in period was critical to significantly reducing inpatient falls and the use of call bell in the adult medical unit.
The fourth article researched is called a staff-led quality improvement intervention in the prevention of falls. The question asked, the study designed and evaluated the use of a specific implementation strategy to deliver a nursing staff-led intentional rounding intervention to reduce inpatient falls. The design was a pre- and post-intervention evaluation study. For the method and population, direct word sampling observations were used. Neurosurgical and neurology patients in a 75-bed neuroscience ward within a teaching hospital/trauma center. For the measurement tool, all statistical analyses were conducted using Microsoft Excel or IBM SPSS independent t-tests. They were used to determine if any significant differences existed. Pre- and post-intervention differences are reported as 95% confidence intervals. According to the article, this study has shown that intentional rounding can be effective in reducing falls.
For our fifth and final article, we chose a qualitative exploration of intentional nursing round models in the emergency department setting, investigating the barriers to their use and success by Kate Kirk and Ross King. The question for this article was, what are the barriers and facilitators as perceived by qualified nurses to the effective implementation of hourly intentional nurse rounds in the emergency department setting? The design, according to Kirk and King, used for this study was a qualitative methodological approach. The method and population used for the study was obtained through purposeful sampling for recruitment. Target population was staff nurses working within the emergency department. Measurement tool used to analyze the data was a framework method of qualitative analysis. The findings of the study, according to Kirk and Kane, found that the staff nurses felt that introduction of intentional rounding techniques could lead to improved patient safety and overall satisfaction. For our evidence-based research project, we want to propose a design of a quantitative experimental design. We would like to do this on two separate med-surg units with adult patients. One unit will implement the hourly rounding while the other will not. In-services will be provided for the unit utilizing the hourly rounding program. Hourly rounding log will be set in place to hold staff for accountability. We will collect data over a 60-day period, and we will compare and contrast our results at the end of the 60-day period.
All staff members will have in-service training, and they will go through training on purposeful rounding. The education will consist of the 4 Ps, safety measures, using bed alarms, keeping the bed in a low position, putting non-skid socks on every patient, keeping the room clean and keeping the floor clutter-free, patient risk assessment, and how to use a log to mark that you have rounded in that room.
The resources needed would consist of a collaboration with all staffing, staff compliance, the use of the rounding logs, an in-service instructor which will go around and teach each staff member the use of the log as well as the purpose, and a fall risk coordinator who would then measure the results of each log. And who are the stakeholders? The stakeholders would be the patient, the hospital, the nurses, and the nursing aides.
The in-service educator will stress the need to use the 4 Ps when rounding. The 4 Ps are position, so asking the patient if they're comfortable, do you need to move up in the bed, or do you need another pillow? Personal potty needs, if they need to use the bathroom, or if they need help getting to the commode or bedpan. Are they in pain? Does the patient appear to be in pain, or are they uncomfortable? Using the pain scale and giving medication if needed. And placement. Is the head of the bed at the correct height? Is the phone, call light, walker, anything they need within reach?
Here we have what we were going to call the bedside hourly rounding log. Any nursing staff member that goes into the room each hour is responsible for signing off on this log. This is the data that we're going to be measuring. We want to know how many patients were admitted on each unit within the 60-day period, how many patients have experienced falls, how many patients were flagged as high risk at the time of admission. We want to know patient ages and cognition, the diagnosis history, and any contributing factors.
To evaluate what is being done, unit coordinators will check in with the nursing staff 3 times each shift to evaluate their thoughts on the process. Nurses will be held accountable for logging their hourly rounding every time they enter the room, the rounding logs, and weekly meetings will be held for debriefing on the hourly rounding.
Now that a plan has been implemented, we need to make sure that it's maintained. And we can do this by evaluating changes in patients' conditions per shift to assess for changes. We will review weekly falls that have occurred with the fall risk coordinator. We will ensure staff accountability, and we will be checking hourly rounding logs to make sure that they're complete and compliant.
Through our evidence-based research, there are some expected outcomes that we hope to see. They include a decrease in the number of falls, an increase in both patient and staff satisfaction, a decrease in the use of the patient call light, a decrease in the hospital length of stay, and a decrease in the hospital total cost.
Falls are a major issue in the acute care setting. Falls attribute to longer patient stays, decreased patient satisfaction, unnecessary injuries, and sometimes death, along with increased hospital costs. By implementing an effective, purposeful hourly rounding program with proper education and holding the staff accountable through hourly logging, we hope to decrease falls, increase patient satisfaction, and overall patient experience.